afternoon. As you just heard, I'm Dr. Cary Fletcher. I'm an orthopedic surgeon from Jamaica. And I'll be talking today on open lock nailing at my hospital in St. Anne's Bay. Now, first of all, I hope to represent my island as well as this young man here. And I'd like to state that I have absolutely no affiliation with Discotech, who are the makers of this expanding nail, or the local distributor in Jamaica. This is an outline of the talk where we're going to be talking about the biomechanics of the intramedullary nail in general. Then we will zone in specifically on the Fixion expanding nail. We'll talk about indications and contraindications of the Fixion expanding nail. And finally, we will close talking about a study involving 57 patients who underwent open lock nailing for a variety of indications. Now, despite the fact that the talk is called open lock nailing, I would like to categorically state that closed intramedullary interlocking nailing remains a standard of care for all long bone fractures that require treatment. The whole purpose of this discussion, therefore, is not to say that open lock nailing is equal or superior to the standard of care. It is that the reality is that even though most of the literature is for first world countries, there are institutions such as mine that can make innovations with facilities that lack equipment and still get acceptable results. So also the point is that poorer nations also need some form of literature to look at for guidance that compare what they're doing with others. So in general, intramedullary nailing is required to maintain the alignment of the bone post-surgery, as well as the length of the bone, and to prevent rotational abnormalities, as well as it ought to be resisting physiological bending forces which will be imparted on the bone after surgery. The nail should allow for contact compression forces at the fracture site, which is going to stimulate healing. So in other words, after you pass a nail, you don't want the fracture ends too far apart and unopposed, or else you will get non-unions. And the nail ought to be accessible if removal for whatever reason is necessary. Intramedullary nailing acts as an internal splint with load-sharing characteristics. What this simply means is that the bone implant construct will share the load between them. That is, some of the forces will be imparted on the nail and the rest will be imparted on the bone. Clearly, though, you don't want excessive forces on the nail, as this will cause the nail to be prone to failure. So there are certain characteristics that determines the distribution of the forces, and one of them will be the fracture stability, whereas the more unstable the fracture pattern is, the greater the load borne by the nail, as well as other features such as the stiffness of the nail and the native bone quality. And as the bone heals, there's going to be a gradual transfer of the forces towards the bone, which will then enhance further bone healing. As with any orthopedic surgery that requires implant placement, there is a race between bone healing and implant failure. Here you're seeing an atrophic non-union of the midshaft of the femur, resulting in excessive strain in these interlocking screws in one of the older intramedullary nails. Now the classic Kunchner nail, which is one of the first, if not the first, intramedullary device that was created, depended mainly on friction to resist these various deforming forces post-surgery. So it required a mismatch between the nail curvature as well as the native bone to provide this friction, as well as a cross-sectional shape, as well as the nail diameter. That is, the wider the diameter, the greater the stiffness of the nail, the stronger the construct. And of course, the canal characteristics, that is of the native bone, that is the size of the canal, the shape of the canal, and the quality of the bone, are also factors that you have to take into account in terms of the overall stability of the bone implant construct. So looking specifically now at the Fixion expanding nail, The majority of cases in my study involved this nail here, this is the classic nail. We did not use the dual interlocking nails. And it's made of stainless steel and consists of a solid cylindrical core. And at the proximal end has a one-way valve to maintain the pressure of the fluid that is inserted in it to allow it to expand. And the reduced diameter of the nail in conjunction with the distal conical tip allows for easy maneuverability to get the nail from one fracture fragment across to the other side. So this now is a complex that allows the nail to expand. I want you to use your imagination, pretend that this is disconnected. So we have this tubing attached to a handle, which is reminiscent of your bicycle pump. And this tubing is inserted in either normal saline or sterile water. You manually turn this counterclockwise, and this fills the pump with fluid. Once this is full, you then turn this clockwise and allow for a few drips of fluid to exit, and that allows for an airtight system. The driver handle is then connected, and then a few drips are let out there, and so the system is now completely airtight. So when you're ready to pass a nail, you disconnect this, attach the driver handle to the nail, a slap hammer that you manually bang the nail down with, passes the nail across the fracture site. When the nail is now in the appropriate position, you reattach this, turn this counterclockwise, and expand the nail. And this is a cartoon demonstrating that. So this is the handle, the driver handle, the pump, tubing system, driver handle, and the nail across the fracture site. So I want you to focus on the cartoon a second, where the fixation nail in its reduced diameter has 4 longitudinal bars, and these are connected by thin membranes. Once the nail is in the appropriate position and you expand it, the 4 longitudinal bars now abut on the endosteum, and this is what gives the interlocking effect. That gives you rotational control as well as axial control, i.e. you're preventing the bone from collapsing down. Now, the endosteal abutment is throughout the majority of the length of the canal, i.e. both cortical bone and cancellous bone. And it does depend, however, on the intrinsic stability of the fracture, whether or not the nail can be used for closed situations. There are several studies out there, for example, that have stated that this nail ought not to be used for comminuted fractures. So briefly looking at the indications, it is mainly used for acute fractures that are at least 5 centimeters distal to the surgical neck, but still proximal to 5 centimeters from the end of the medullary canal. That indication number 1 was the vast majority of cases in the study that we're going to be looking at. It also may be used post-osteotomy and deformity correction for non-unions and malunions, reconstruction post-tumor surgery and or impending pathological fractures, as well as for revision surgeries where other implants have failed. For the contraindications, it's contraindicated for very proximal or distal fractures, that is outside of the 5 centimeter parameters mentioned on the previous slide. Now, interestingly, 2 and 3, the highly comminuted fractures and the longitudinal split, are contraindications because when the nail is expanding, you can actually iatrogenically worsen the pathological process. However, in our study, because we perform this procedure open, and open here means that you're exposing the fracture site as opposed to making your incision at a remote distance away from the fracture site, we use cerclage wires. For the non-orthopedists, those are malleable wires that you can literally rope around the bone and basically make that fracture pattern more stable. So we basically went outside and beyond the literature and turned this contraindication into an indication in terms of how we do the technique open. And of course, Infection, poor bone quality, and foreign body sensitivity are also contraindications. So finally, I'm going to be looking now at the study that we conducted between 2008 and 2012. We treated 57 patients with a fixation expanding nail. The majority, as I mentioned earlier, were acute fractures, where 44 were femoral, 6 tibial, 3 humeral, and there were 4 other patients, 3 of which were non-unions, 2 humeral, and 1 tibial, and there was 1 femoral pathological fracture. Now, as with most trauma, males tend to dominate, so we saw roughly a 4-to-1 male to female ratio. 98% of our injuries were closed, and the mean age for the patients were 38 years old, with the ages ranging from 80 to 90 years old. And the mean follow-up time in the study was 44 months, with the ranges from 6 months to 70 months. Now, my hospital is located right outside one of the major highways in the country, and this is an actual car accident on the highway outside my hospital. 53% of the patients presented because of a motor vehicle accident. Another 30% presented because of a low energy fall. And then the rest were deemed miscellaneous for a variety of reasons for blunt trauma. The most interesting case being one gentleman who presented because he was kicked by a cow. 19 patients had concomitant injuries, for which head injuries was the commonest concomitant injury. Ignore the slide. The main thing to get out of this is that we use in the study the AO classification, which is a very cumbersome classification used really for studies and not clinical use. But simply put, AO type A is a simple fracture pattern. Type B, you have a small butterfly fragment. And type C, you have various degrees of comminution. The majority of our cases were AO type A and B, and as mentioned earlier, several authors state that you shouldn't use it for type C. However, we were able to. So each patient got a single dose of antibiotics intravenously approximately 15 minutes prior to incision. All of the lower limb patients, except for one, had spinal anesthesia. And because we don't have a fracture table, and for the non-orthopedists, a fracture table is a specialist table that allows you to jack the limb out to length, and then you put in the portable x-ray and reduce the fracture for you. We don't have access to a fracture table, and we don't have fluoroscopy, and so all of the procedures were performed open. And we don't have power reamers, and so we had to use solid K-nail reamers. Now, the time between injury and surgery for our patients averaged 17 days, closer to 18 days, and the thing about it is this: in our circumstance, our patients actually have to purchase the implant prior to getting surgery. So this waiting time is mainly because we have to actually wait on the patients to purchase the implants. For those who can't afford it, they usually get a K-nail. And the time between surgery and discharge was 4.8 days. Now, once again, a bit misleading. Most of our patients can be discharged within 48 hours, but there are a number of social issues, especially the fact that we're a regional hospital. A lot of the patients come from several miles away. Now, our mean operation time for the femurs averaged 102 minutes, for the tibia 66.4 minutes, and the humerus 94 minutes. Now we have shaved off approximately 10 minutes off of that mean time for the femur and the tibia. And this is mainly due more to the assistance experience than the surgical experience, actually. And so we've gotten more efficient. And these times compare favorably to a number of studies in which they've performed the procedure closed. Our blood loss, the femur averaged 400 mils, ranging from minimal to 1.8. Now, 1.8 is a frightening figure. Now, the thing about it there, though, is that for the AO type C, the highly comminuted fractures, especially those that had a large segment, A lot of times those patients required a large incision and significant stripping in order to reduce this fracture. I haven't personally been involved in a case that the blood loss has been more than 800 cc's. But once again, I think it is more the experience of the assistant more than me. And the tibia, 120 mils average, humerus 250 mils. So preoperatively, 8 patients required transfusion, mostly polytrauma patients at an average of 2.25 units. And postoperatively, 6 patients required transfusion at an average of just under 3 units. All of those patients were the AO type Cs and or those patients that took over a month to get into the operating theater. So at that time, you're breaking down soft callus and more bleeding and stripping. And 3 out of those 6 patients were transfused preoperatively. So looking at our results in terms of partial weight bearing and fully weight bearing, we allowed partial weight bearing when there was reasonable amount of callus on the x-rays. Of course, that is very subjective. And this we did for all our patients. There are some authors who allowed immediate weight bearing. However, Jamaican patients, you can't trust them to immediately weight bear because some might even climb trees or run marathons. So we prefer to err on the side of caution, and we wait for some amount of callus before allowing for some weight bearing. So the key figure here is that at 14 weeks, we allowed full weight bearing for the femur, 16 weeks full weight bearing for the tibia. This was allowed when there were at least 3 to 4 cortices, 3 out of 4 cortices healed on plain x-rays when you summate the AP and lateral views. The humerus averaged 12 weeks in terms of union, and at around 3 months we allowed for them to aggressively use their limb. But in the meantime, up to that 12 weeks, we allowed for gentle passive range of motion exercises, namely for the elbow and to a lesser extent the shoulder. So looking at our complications, we didn't have any cases of broken tips. Several authors have mentioned this as a complication. However, we believe that because we perform this procedure open and the fact that we have a relatively well-controlled reduction, the nail can easily slide across with very little trauma and problems. We didn't have any cases of iatrogenic fractures, even despite the fact that we went above and beyond the indications, i.e. we did it for comminuted fracture patterns. All of the nails expanded, and this is something that has been reported in a number of series that some of the nails don't expand. We had no cases of malrotation, shortening, or angulation deformities. However, I will admit that since this is done retrospectively, this may not normally be routinely checked for in the clinic, and so a prospective study would better be able to define whether or not that really is so, especially malrotation. We had 1 case of radial nerve palsy following a humeral fracture surgical procedure. All of our patients healed. We had 2 superficial infections in which they were successfully treated with intravenous antibiotics alone. 1 deep infection, we allowed them to get an infected union. We then removed the nail and then reamed out the canal and placed gentamicin beads, and they were successfully treated. And we had 1 case of pulmonary embolism in an elderly patient that had bilateral tibial fractures. 9 patients complained of persistent pain in the clinic, of which 5 were femur, 3 tibia, 1 humerus. We identified an obvious cause in 5 out of these 9 patients. And 4 out of those 5 was the fact that the implant was a bit proud at the hip in a femoral nail. Now, of all of those patients that had nail removal, all of them went on to do significantly better and had no complaints. So, in conclusion, it may be used for acute fractures within the recommended parameters mentioned earlier, may be used to treat non-unions, The operative times, blood loss, and complication rates were deemed to be acceptable. We had 100% union rate and no good axial rotational and bending stability. Now, just to mention this, just to explain something else in my country, that we're a regional hospital and we usually have type A hospitals in the city areas that have the standard of care equipment. However, these centers are frequently overburdened. So in my training where I was trained there, it was not uncommon for these patients to be placed on traction and be definitively treated on traction because simply there were more patients than operative time. And so we believe, therefore, that acceptable results at our institution using a procedure that is not said to be standard of care justifies non-transfer of these patients. This study was published in Journal of Orthopedics and Rheumatology last year. Thank you. These are my references.